As I told you, usually the most common injuries around the knee, especially in the case of sports medicine, is the knee injuries, especially the intracapsular, which is the ACL and the PCL. The problem of this is the magnitude of this injury is such that actually this has been suffered by some of the most important sportsmen. For example, if you take the players, especially soccer players or even the American football players, they may be taking millions and millions of dollars in terms of their fee, in terms of their contracts and all that. And then there is a lot of money involved as well. For example, if a player is at the peak of his performance during the peak of his career and suddenly suffers a knee injury, and which is, for example, mistreated or not treated properly, and that results in a loss of a career, it's not just that the career is actually lost for that player, but the problem is of the lot of money which is get lost as well, because there is a lot of money which is coming in terms of promotions and other advertisements and all that, plus there's a lot of money playing as well. So knee ligamentous injuries actually kind of a issue which needs to be dealt with meticulous care and with meticulous expertise. Now we are coming into the brief anatomy of the knee. As you know, this is the lateral view of the knee, which is showing some of the structures. As before told you, there are intracapsular structures, which is inside the capsule, then extracapsular structures. This is the ACL, which is actually PCL, which is actually lying inside the capsule. You can see it from here. There's the ACL and then there's the PCL. ACL is called as anterior cruciate because starts more anteriorly, goes up, turns more laterally, and then attaches on the medial border of the lateral femoral condyle at around 10 o'clock position. PCL starts more posteriorly, ascends upward, and then turns more medially, eventually attaching on the 11 o'clock, on 1 o'clock or 2 o'clock position. Then there is a capsule structures as well. This is the posterior articular capsule. This is the lateral meniscus. This is the medial meniscus. Then there are other structures which are around the capsule as well. There are different stabilizers. There are stabilizers which are inside the knee joint, such as ACL, PCL. Then there are stabilizers which are outside the knee joint. One of the stabilizers is capsule itself, which is surrounding both the bones, as well as certain ligaments which are around outside the capsule, such as medial collateral ligament, lateral collateral ligament, even the patellar tendon, which you can appreciate it over here. Now this is an AP view of the knee. If you see it, the patellar tendon is actually a cords. All the cords are actually coming in, attaching it on a patella, and then forming a patellar ligament which is attaching on the tibial tuberosity. This is the most important restraint of the extracapsular restraint. But then there are other structures which is fibular collateral ligament or lateral collateral ligament. Then on medial side, this is called as the tibial collateral ligament as well, which is also called as medial collateral ligament. Now knee ligament injury, there's always a mechanism. So, there's certain kind of a falls or certain kind of a patterns which actually result in either ACL or PCL injuries. Now, before you understand the mechanism, you need to understand what is the function of ACL. The ACL is attached in such a way that it actually prevents anterior translation of tibia over the femur. So if the ACL is torn, that what would happen is when during the flexion extension, what would result is that the tibia will be anteriorly translated. So how does the ACL injury can occur? One way is actually the contact injuries. For example, in rugby or in sports such as American football, what happens is there is always a tackle which can come in, and there is always an injury can occur along with it due to contact injury. But for example, if you take a sport, for example, soccer, now in that it's mostly actually a non-contact injury. The knee is usually hyperextended with the foot planted on the ground. If you see, this is the situation. This is the position with the foot planted on the ground, and knee is actually hyperextended. If you can appreciate, there is slight valgus actually already stress on this knee as well. In that case, what happens is if there's excessive anterior translation of the tibia due to any force or any tackle, what results in actually the ACL tries to resist that excessive traction and results in a rupture. So this is the most common mechanism in case of soccer. But if This could be common if in case of rugby there could be a contact tackle which could lead to ACL rupture as well. But the important point is to remember is that usually the knee is in extended position and ACL is actually tight, so to prevent the anterior translation of tibia, and once the forceful anterior translation occurs, this results in a rupture of the ACL. Other sports, for example skiing, this can also result in ACL or even a PCL rupture as well, but usually that's actually also a non-contact injury in which the foot is actually planted on the ground or it's actually static. At that point of the injury, there's a rotational element along with the anterior translation leading to ACL injury. And this is very common. What happens is it's always most commonly the knee is in extension with forceful anterior translation tibia with the foot planted on the ground leads to ACL rupture. So as I told you, the ACL is actually has two bundles, anterior medial bundle and posterior lateral bundle. What is important is that these two bundles originate and attach. One anterior medial bundle is tight in flexion, posterior lateral bundle is actually tight in extension. What is, as you can appreciate, it's starting more anteriorly, going upward, backward, and then going laterally, attaching onto the medial aspect of the lateral femoral condyle, and on almost at 10 to 11 o'clock position. If you see this, if the tibia will be translated anteriorly, this will get stretched. If it's translated too much anteriorly, eventually it will not only resist anterior translation, once this there will beyond its limitation to resist, it will actually fail and lead to rupture. Usually there is could be most common is always a mid substance tear, which is actually happens at this level, but sometimes instead of having mid substance tear, this ACL ruptures along with this bony avulsion of the tibia, which can represent with the bony avulsion of ACL injuries along with the tibial eminence fractures as well. So depending upon what was the force, how long was it applied, and how much force was actually applied may lead to rupture of the ACL, as I just told you over here. And if this gets torn in the mid substance, now there will be anterior translation, there will be no actually resistance to anterior translation of the tibia as well as external rotation. So then when patient will walk with the torn ACL, there always complaints of giving way of the knee, that the knee suddenly tibia goes forward and patient feels as if the knee is actually coming out. So that is the reason, because there is no actually restraint to the anterior translation of the ACL. Now coming to the instability, how would you know actually that ACL was torn? Some points in the history are always very much giving you a clue. For example, usually it's a sports injury. If there are even a sportsman is coming as somebody who's actually, he would tell you that, okay, I was playing soccer, I was playing rugby, I was playing the American football, and suddenly I had a tackle. During the tackle, I felt a pop in my knee and something went wrong, and after that I'm not able to bear weight, and as within few hours you can see that my knee is actually swollen. So this is a classical history of ACL rupture, that usually there is pop, suddenly as the ACL ruptures there is a lot of hematoma because the blood is actually being supplied with the medial geniculate artery. This leads to a lot of hematoma collection, leads to swelling of the knee, and due to acute injury, pain and swelling, that actually the patient is not able to bear weight on the knee. So that is actually also a clue that you ask the patient or that sports person that, okay, were you able to continue your play after that? And he would say, no, I wouldn't be able to. That I had to leave the play right over there because I was not able to bear weight on my knee. So once if there is acute swelling, you should not be dealing with it. The only initial treatment is actually to give pain analgesics, so that once the swelling settles down, you can check for the instability in a week or 2 times, and that is actually through 2 tests. One is anterior drawer, which can be seen over here, and other is the Ligament. Ligament is more sensitive as compared to anterior drawer, but both actually tests are done for ACL injury. This is how you do an anterior drawer with the 45-degree flexion at the hip, 90-degree flexion at the knee joint. The foot is on the couch, patient is lying supine, and the foot is actually planted on the couch when the examiner starts sitting on the foot, so the foot cannot move. And with after the relaxation of the muscle, you push the tibia towards you or towards the examiner, that is, push the tibia more anteriorly. Once the tibia is pushed more anteriorly, if there is ACL injury, this will result in a gross translation of tibia anteriorly. And this is actually a pathognomic, but you have to compare it to the other side as well. Sometimes some people have actually a bit of a laxity as well, that is also present on the other side as well. So you're not sure whether this is acute ACL or it's actually just the laxity of ACL, which is present on both sides. The best way is to compare it on the other side, and if you see gross anterior tibial translation on the affected side, on the side on which the patient had a trauma, as compared to the other side, this is means most likely there is an ACL tear. The other is, now if you see this was the tibia over here, and here, how much it has actually translated out. If you can see the patella, it looked like it sank in and then it is actually coming out. Now other is the Ligament. Ligament test is relatively difficult to perform, but it's more important or more sensitive for the ACL tear, because if you see, this looks like a very small, it's not a bulky leg. Sometimes, especially in case of those patients who are sportsmen, they have very much hypertrophied muscle as well. So it's one way of performing that Ligament is to hold the femur with your one hand and hold the tibia with another hand. And once you hold the femur with left hand, you push the tibia anteriorly. If you are able to do that, this means the ACL is injured. But sometimes that thigh is actually very bulky, especially in the case of sportsmen. So what you do is you put one of your knees right over here so that you can get 30 degrees of flexion at the knee with almost 20 to 30 degrees of flexion at the hip joint. That is what you need. And you can stabilize the thigh by pushing your hand from top towards your knee, so that you can actually stabilize the hypertrophied muscles of that sportsman between your knee and one hand, and then you push the tibia forward. That is one technique of just making sure that you perform it correctly, because you need a bit of a 30 degree of flexion and 20 to 30 degree flexion of hip as well as knee joint. But Ligament test and ACL anterior drawer test are actually pathognomic of ACL injury. If they are coming positive, then could be +1, +2, or +3, depending upon how much translation is actually there. 0 to 5 mm translation is +1, 5 to 10 mm translation is +2. More than 10 mm for translation means the tibia can be moved anteriorly almost more than 1 centimeter, which means it's a grade 3 ACL tear. Now coming to the imaging. After taking history, after making the examination, you are almost pretty sure that you have got things, but you need to confirm it by imaging. One option is to get x-rays. You have to get AP lateral view of the knee because the knee is the injured part, but some of other imaging which is usually required is MRI. On knee, the most important thing to look for is, if it's an ACL injury, is to look for a C-joint fracture. What is a C-joint fracture? Because usually what happens is, as I told you, the mechanism of ACL is such that it prevents anterior translation of the tibia over the femur as well as external rotation. So if there is an ACL injury, this means the force which was actually acting was more anterior as well as lateral. So you have to check at the anterior lateral compartment for C-joint fracture. Why? Because if there is always associated anterior lateral ligament or ALL of injury, this results in usually a C-joint fracture. And a C-joint fracture means on X-ray, if you see it on AP view, this is kind of a telltale sign that it is ACL injury. Other is MRI. Obviously you have a coronal view as well as sagittal view. On coronal view, you have to look at into the intercondylar notch. What is important is that in a normal person, if you get an MRI, you will see a crisscross pattern of ACL and PCL. But on a coronal view and that intercondylar view, if one of the ligament is torn, that crisscross pattern of the ACL and PCL crossing each other in form of cross is actually absent. And when you take a sagittal view, this is usually see. This is anterior side, this is the posterior side. If you can appreciate over here, this is T2 image. How we know it's a T2? Because the ligaments are actually appear darker, and on T2 the water appears bright while the structures appear a bit blackish. If you see this is the ACL going in, but I cannot see more because this is probably a mid substance tear right over here, and then you is lost, and then there is the PCL as well. PCL may be sprained, but definitely there is an ACL rupture, and most likely it's a mid substance rupture. So the important point is to get X-rays, to get MRI, and to make a diagnosis along with the history and clinical examination. Once you made the diagnosis, actually the treatment has evolved over time, but in 70s and 80s there was actually an attempt of repair of the ACL, which unfortunately did not produce results good enough to continue with that kind of treatment. Then there was also a few research articles regarding augmentation of ACL, but that did not work out as well properly. So now the focus actually shifted off reconstruction of ACL. Because if the ACL will be deficient in the knee, the problem would be the kinematics would be such that patient would complain that his or her knee actually gives away during walking. Because in extension, when the foot will be planted on the ground during the walking mechanisms, what happens is the tibia translates anteriorly as well as laterally. This leads to patient giving away a feeling that probably the knee is coming out. So for a sportsman, it could be disastrous. Just imagine a soccer player who had an ACL injury, and if we are not able to reconstruct it, or if the reconstruction is not done, he or she will not be able to play or continue with his career. So the treatment options could basically two things. That is autograft of the ACL, which is in form of BTB graft or bone patellar tendon bone graft. This is how you take it out. This is the patellar tendon, and you take out some block of the bone along with the patellar tendon and some block of the bone from the tibial tuberosity as well. And why this bony part is actually taken? Because bone to bone union, when you are attaching this into the intercondylar notch along with the femur, bone to bone union is much better than bone to tendon union. So that is why a bone patellar tendon bone graft is taken, and that can be open repair can be done as well, open reconstruction, and nowadays it's very common to do an arthroscopic all inside or inside out reconstruction of the bone patellar tendon bone graft of the ACL. Another option is always available as well. For example, some people don't like it because it has its own pros and cons, because later on there is always anterior knee pain. There may be some decrease in strength of the quadriceps as well, but few people like to harvest the hamstring graft, which is actually other option is actually to do a reconstruction with the quadrupled hamstring graft as well. As I've just told you, this is how it is taken, and it's attached with suture anchoring done at the tibia as well as over the femoral level. Other option, this is normally you see it in case of what happens is this is all arthroscopic is actually done. First, a tibial tunnel is made up to this point where the ACL footprint is there. From then onward, they make a femoral tunnel, and then they harvest the graft and pass it through the tibial tunnel into the femoral tunnel over here, and eventually all this can be done through arthroscopic procedures. The other option is a use of hamstring graft actually. Now the second option, we will be now discussing the posterior cruciate ligament. Then this is also a common intracapsular ligament injury, but as compared to ACL it is way too less. Now PCL, as you know, we'll be discussing briefly the anatomy as well, which we've just discussed it actually. It starts more posteriorly, goes more anteriorly as well as more medially, and actually attaches on 1 to 2 o'clock position. The mechanism of injury is such that as compared to ACL in the knee was either hyperextended or in extended position, and when the excessive anterior stress was placed. In case of PCL, it's actually the mechanism of PCL is to prevent the posterior translation of tibia over the femur. So that if there is a hyperflexion injury, for example, a person is falling with the foot in plantar flexion or in equinus, or the dashboard injuries classically which is seen in the car crashes, that the patient has actually, the car has crashed into something and there's sudden deceleration of the dashboard hitting the knee with the force is mostly anterior and is actually pushing the tibia posteriorly. There will be some degree of the translation of posterior tibia, then there will be resistance with the PCL. But if the force would be too much, this would really result in rupture of the PCL. Now, what is important in the case of PCL is to know that it's not an isolated PCL. It could be a PCL associated with posterior lateral compartment, which is PCL with PLC injury is actually usually common, but we have to differentiate whether it's an isolated PCL or PLC injury as well. Other option could be in skiing as well. For example, during skiing accident, sometimes what happens is that if a person goes and hits a wall or let's see a tree, something like that, and as the foot is actually planted on the ground, the force is coming anteriorly and taking the tibia, pushing the tibia more posteriorly, leading to PCL rupture. What is important is, if you can appreciate over here, as I just told you, it starts more posteriorly, ascends upward and anteriorly, and eventually going medially, attaching it on 1 to 2 o'clock of position. Now, if you see, this is a view from posteriorly, and you can appreciate the mid-substance rupture of the PCL, which is usually mid-substance. Now, coming to the diagnosis. First of all, it's always the history. Usually the patient tells you that, okay, I was falling with knee was flexed, with my foot was in equinus or hyperflexed. This is also a telltale sign that probably the PCL injury was there. Or if there was a history of car crash with a dashboard injury, probably most likely the first thing we would have injured is PCL. Or then it could be sometimes, if it's not clear from the history, usually the injury is not that acute as compared to ACL. There is definitely a pop, there is definitely some degree of swelling as well, but it's not that much as compared to the ACL. Then once we after the history comes the clinical examination. The two important tests is actually, one is the posterior drawer and the second is the quadriceps active test. Posterior drawer, as the function of the actually PCL is to resist the posterior translation of the tibia. So in the posterior drawer, what is actually happening is 45-degree flexion at the hip joint, 90-degree of flexion at the knee joint, and the foot is stabilized by the examiner sitting on the foot. Therefore, the foot cannot go anteriorly. What happens is the patient examiner pushes the tibia instead of in anterior drawer, they were pushing the tibia towards him or herself. In this, actually the examiner pushes the tibia in opposite direction. If there is a PCL injury, posterior tibia will actually just sag beyond the level of the femur, which is actually indicative of a PCL tear. Now, other options after the history examination are actually always the X-rays. We can have always X-rays are always AP and lateral view. You may not have some associated injuries may get picked up. There may be bony avulsions, but MRI would be the ideal, most important. Similarly, on the coronal view, you will see the absence of that crisscross pattern. Similarly, on the sagittal view, you can appreciate that this is the PCL which is starting. There's some edema over here and actually going up. This probably T1 image, as it is showing some degree of edema and fall as well. PCL rupture can be appreciated over here as well on this MRI. Now, if you see this is probably a T2 image. This is further delineating the PCL. As you can see, it's over here. And there's actually a substance. It's not a mid substance. It's more of a avulsion from the tibial aspect, which can be appreciated on the MRI. Now, initial treatment with the PCL was actually, as if the ACL is intact and there's isolated PCL injury, then the first and foremost is actually start with the rehab of the patient. Patient can be given analgesics, rest for a few weeks, and then we can start with the rehab. If the rehab is good enough, mainly it's actually the quadriceps strengthening exercises such as this one, or these are some of the exercises. Then there are certain squats as well, and as you can appreciate is these hamstrings. These are the hamstrings strengthening exercises. These are the quad strengthening exercises, and usually that kind of in grade 1 or 2 T, that is more than enough. But if it is a complete tear or it's a bony avulsion, then that may require reconstruction as well. And nowadays with the PCL injuries, the most commonly PCL can also be reconstructed by use of hamstring graft as well by all arthroscopic techniques. Now coming to the bony avulsion of ACL and PCL ligament is avulsion. Now why they're important? Because when you have ACL and PCL along with the bony avulsions, which actually means there was a high degree of trauma. If you see, this is an AP view. You can also appreciate that inside the notch there's also tibial spike fracture, as well as this increased medial side opening as well. So this could be associated with medial collateral ligament injury as well. If you see, this is the same on the lateral view. Can you appreciate that there's a flak of fragment which is actually coming more anteriorly? So this means this could be a avulsion fracture along with the ACL rupture. If you see it over here, this looks also on the AP view, tibial spine fracture. But if you see on the lateral view, this spine is actually coming more posteriorly. This means this could be a bony avulsion fracture along with the PCL rupture. So bony and PCL ligaments avulsions have to be treated because they can not only produce the problems which is associated with stability, the problems could be with the arthritis as well, because there's intra-articular fragments. So they have to be either open reduction tunnel fixation with screws and staples, or it could be all arthroscopic reduction with screws and staples. This is what screws can be used as well, and sometimes the staples can also be used depending upon it's arthroscopic or it's open. Different techniques can be employed. Now coming to the extracapsular ligaments, which include the medial collateral ligament as well as the lateral collateral ligament. Now, as you know, the medial collateral ligament is actually torn, especially with the increased valgus stress. What is valgus stress? Is the stress is coming from the medial side in such a way that it's actually taking the distal part, which is the foot and ankle, more laterally or in the valgus. This is called as valgus stress. When too much valgus force is actually applied, as you can appreciate it over here, this means this will result in collapse of the, if you see, the force is actually either coming from this side, pushing this distal part more laterally towards the fibula. This leads to valgus stress and tear of the MCL. Now, there are different grades of MCL tear. As you know, there are two, basically, if you know the anatomy, there's superficial MCL, there's a deep MCL as well. Now, depending upon how much translation can be actually seen on examination. If it is 1 to 4 mm of medial opening, this is actually grade 1. And usually it can be treated with bed rest, analgesics, and you don't need the surgical repair of it. If it's almost 4 to 8 mm or 9 mm of translation, that is actually grade 2 injury. And when you are doing the valgus stress test for this MCL, you can compare the medial opening of this traumatic knee along as compared to the other knee. If it's 10 mm or more than 10 mm of a translation, is usually grade 3 injury, which can be appreciated on this MRI as well. You can appreciate this mild, this more moderate, and this more severe. Grade 3, grade 2 usually requires some degree of bracing, bed rest, analgesics as well, and then gradual rehabilitation into normal activity. But grade 3 usually requires a repair. If it's an isolated MCL injury, this could be repaired, but if it's associated with ACL, then you have to repair MCL, then as well as reconstruct ACL as well. Now coming to the lateral collateral ligament. In case lateral collateral ligaments are actually prevent varus translation of the tibia. If there's too much varus force, which is actually taking the distal part of the tibia more medially, then this can lead to the rupture of lateral collateral ligament along with the rotatory element as well. If you see, this is the MRI, this is the fibula, so this is the lateral side. You can appreciate this actually tear of lateral collateral ligament as well, which may or may not be associated. It could be isolated LCL injury, or it could be associated with ACL or PCL as well, and usually is more commonly associated with ACL. Now, testing the collateral ligaments. Collateral ligaments can be tested by applying actually the varus and valgus stress test. Now, there are two ways of applying that test. If you see this, in this, the patient is lying supine on the couch with the hip is in 20 to 30 degree of flexion with knee in extension. One way is you can apply it in extension and look for how much varus and valgus actually opening, medial or lateral joint opening has actually taken place. Other option is that take this knee as well into 30 degree of flexion and again apply a varus and valgus stress. That will actually relax a bit of muscles, because in this kind of a sometimes what happens is there is iliotibial band as well which is acting on it, especially when there is lateral collateral ligament injury. In extension due to iliotibial band contracture, we are not able to fully appreciate how much the LCL injury is there. On complete extension it looks like grade 1 injury, but when you just slightly flex the knee and again do the varus stress test, it comes out to be grade 3 LCL injury. So that is very important that you have to do it in full extension, always in full flexion, 20-30 degree of flexion of the knee as well. Then comes the quadricep active test. Quadricep active test is actually mainly done for the PCL injury. If you see, as I told you, the PCL prevents the posterior translation of the tibia. If the PCL is injured, the tibia would be sagging posteriorly. What happens is the patient is lying supine on the couch with 45 degree of flexion at the hip joint, 90 degree of the flexion at the knee joint. If the foot is actually made stationary by examiner's hand, or other option is that examiner can sit on the foot and ask the patient to straighten up the leg in this direction. As the foot is being actually planted on the couch by this examiner, as he or she is actually sitting on the foot, so the foot will not move. But what happens is this extending the knee joint would actually contract the quadriceps. So if the quadriceps will contract, actually what happens is that this sagging is actually countered by tibia translated anteriorly. If that has happened, this means there is a PCL injury. And if despite this, PCL injury could be associated with ACL injury as well, or this could be isolated PCL injury as well. Now coming to the knee dislocation and multi-ligamentous injury. Usually, even the isolated ACL, PCL easy to manage. Even in the case of sports, there's always either anterior medial complex injuries and lateral complex injuries as well. But if it's a massive trauma or high energy trauma, this leads to knee dislocation. If you see it on AP view, it looks like more of a medial rotation, but you have to look at the lateral view as well to check it out whether it's posterior medial or anterior medial, or it's posterior lateral or anterior lateral. So on AP and lateral view, we assess whether this is where actually the dislocation has taken place, when we are assessing in terms of where the tibia is going. If tibia is anterior as well as lateral, this is an anterior lateral knee dislocation. Tibia is posterior and lateral, this is posterior lateral knee dislocation. So other options for dislocation is actually the MRI as well. If you see, this is MRI. This is showing sprained PCL as well. There is torn ACL, and you can appreciate the medial side. Now this side is actually the lateral side. This is the medial side. Almost all the structures of the medial are damaged. There's medial meniscus tear, medial collateral superficial D, both are damaged. There may be bone bruising over here as well, along with the side. This means this was a dislocation, most likely either it was posterior medial or anterior medial dislocation, leading to this kind of a problem. Now, if this is what happens, is what is the first line of treatment for any dislocation? The first and foremost is close reduction of the dislocation. If once we do the close reduction of that, what type of dislocation it is under the GA, you stabilize it, and you apply the splint on the knee and ask the patient to give analgesics and then give bed rest for 2 to 3 weeks. And once the swelling has settled down, the pain has actually settled down, then you assess for the instability of the knee, whether it's rotary instability is there, anterior lateral, anterior medial, isolated anterior, isolated posterior, whether it's ACL, PCL, ACL along with MCL or LCL, then you have to assess it whether what type of injury is actually there. Then after that you start the management or treatment options depending upon what type of injury it is. As I told you, the foremost method is to, if there is acute dislocation, is the initial management of the close reduction of the dislocation under GA. And how do we do it? The way is to actually apply forces contralateral to the actual injury. For example, there was anterior lateral translation of the tibia. This leading to anterior lateral dislocation. So you flex the knee, you hyper dislocate the knee, then as you extend the knee, you apply the pressure from the lateral side towards the tibia so that it actually goes back in, and this is how you reduce it. Whatever, if it's posterior lateral, it would be slightly pulling the tibia back into the articular groove. So that is how, whatever the force was actually creating the dislocation, you apply exactly the opposite force to relocate the joint. Now, once we have done this, for example, it's a multi-ligamentous injury, it needs repair along with the reconstruction of ACL or PCL. In this, you can see that there's actually the medial collateral ligament has been reconstructed, along with it the ACL, PCL reconstruction has also been done. And different methods are available. We can go for bone patellar tendon graft for ACL, and hamstring graft can be used for MCL or LCL reconstruction as well. So this is how you treat the multiligamentous injuries. If there's ACL or PCL injury, you need reconstruction. And if it's medial collateral along with lateral collateral ligament injuries, if repair can be done, that needs repair. If it is reconstruction, then it can, different muscle or hamstring grafts can be used to actually reconstruct the medial lateral collateral ligament as well. In this, actually, we have discussed the multiple ligamentous injuries of the knee. We have discussed isolated ACL or PCL injuries, which is the most two common intracapsular injuries. Then we have discussed some extracapsular injuries as well. That is the medial collateral and lateral collateral ligament as well, along with the multiligamentous injuries. Usually isolated injuries are rare, but they can occur in isolation as well. But most commonly, when there is multiligamentous injuries, that requires reconstruction and surgical options. But isolated low grade, grade 1 and grade 2 injuries can be managed conservatively. So keep watching sqadia.com. Thank you very much.